One of the most fascinating things about long COVID and post-viral illness is the fact that the viral infection may trigger the nervous system to engage in a process called dysautonomia, where the autonomic nervous system is dysregulated, and we see a wide range of symptoms, anything from postural orthostatic tachycardia syndrome and nausea, dysmotility, and all sorts of systems that are normally regulated that we don't even think about can get thrown off in the process of getting an infection. Hello, everybody. I'm your host, Dr. Adam Rinde, and this is the next episode of the One Thing podcast. I'm welcoming on Dr. Robert Groysman out of the Dallas, Texas area, who I met when I was searching for guidance on how to use transdermal vagal nerve stimulation. He happens to have just an amazing library of information that he's shared over social media to help educate practitioners and people who are dealing with long COVID and other related conditions that have dysautonomia, helping them learn how to intervene and balance the vagus nerve through these electrical stim techniques. He is not only known for that, but he has done a number of other techniques to treat trauma-related disorders, as I mentioned, post-COVID syndrome, and other conditions related to dysautonomia. So in this episode, we dive into the basis of these therapies. We'll get into techniques such as stellate ganglion injections, his process of addressing a long COVID is covered in this episode, and of course a deep dive into learning about vagal nerve stimulation. I've been very happy to introduce my patients to vagal nerve stim, and it's provided a lot of relief through this process and is something that I'll be using for years to come. So I look forward to sharing this information with you. And without further ado, welcome to the next episode of the One Thing podcast. And before I start the episode, please subscribe and share our episodes with your friends and loved ones. Thank you very much. So great to finally meet you. Thank you for putting up with my difficult to reach schedule.
My pleasure, Adam.
Great. I know that we have a lot to talk about today, and I'd like to just first get to know you a little bit better. And it sounds like you grew up or lived in New Jersey and now live in the Dallas area. How did you end up, first of all, getting interested in medicine? And tell us a little about your journey in medical school, how you picked the specialty you're in.
Boy, did you open up a can of worms. I'm actually a first generation Ukrainian. I come from Ukraine when it was part of the USSR. We moved to New York and then moved to New Jersey. But I knew that I wanted to be a doctor even at 4 to 5 years old.
Okay.
So that's how it started, my curiosity in the human body and how things worked in biology, physiology. And I went to Robert Wood Johnson Medical School. Now it's called Rutgers Medical School.
Yeah.
And I trained there in anesthesiology. Then I had additional training in pain management. And how I got started in long COVID is I was treating PTSD using stellate ganglion block procedures. And this was very early in 2020. And we started seeing patients who had no smell or taste. We had no idea what it was or what was causing it at the time. And surprisingly, that was coming back. Their taste and smell, that they didn't have any other symptoms. That's all they were presented with. And it was a smattering of people, but it was enough to get the gears turning, that something was going on. And before long, we figured out that COVID was responsible for that. Those are my humble beginnings with long COVID.
Okay. And backing up a little bit with the stellate ganglion blocks. Now, that is a very significant treatment, as you mentioned, in the PTSD world. Can you? So that leads to this connection with long COVID of dysautonomia. So can you talk about when you started doing that procedure and sort of your experience with it?
Sure. I started the procedure about 5 years prior to that. The way it works is that in PTSD, it's not a mental condition as many doctors think. It's actually a physical condition where the amygdala, which is a part of the brain in the temporal region, which means the side of the brain, where memory is stored. And this particular memory is emotional memory. It's something that's very significant to you personally. And in PTSD, that area of the brain gets overwhelmed to such a point that it starts releasing the signals all the time, creating things like hypervigilance and anxiety and sleep disorders. And all of that basically drives the sympathetic nervous system or the fight flight. And you're essentially in a dysautonomia constantly when you're under PTSD. So, what this procedure does is it disconnects temporarily the relay center between the brainstem and the brain and the rest of the body, so that even if you have those memories and emotions, they're not linked anymore. So it lets you separate them and lets you process those memories outside of feeling those emotions that are connected to those memories. And that's really the key to the success to this procedure. It completely reduces or removes the sympathetic overdrive. Part of it is determining which side dominant you are. And it has nothing to do with your hand or your eye or your foot. Your body just picks one stellate ganglion to shoot through more often than the other. Some people are non dominant, which means that both sides are used equally, which means both sides need to get blocked.
Hmm.
So I've seen tremendous success with this procedure and upwards of 80 to 85% of relief of symptoms, including improved sleep, in reduced anxiety, and all of the associated symptoms of PTSD.
Hmm. Okay, and so this bridges to long COVID. How? There's most people think of the long COVID from a very basic level. It's a virus, maybe impacting the lungs and maybe impacting a little bit of the cardiovascular system. But where did you see the link between dysautonomia and long COVID?
Dysautonomia is what keeps long COVID going.
Mm.
It dysregulates the immune system. So when you are in fight flight, not just your body gets all excited that there's an emergency going on and there's danger everywhere, your immune system also sees that. And all of a sudden, inflammatory mediators are released and white blood cells start to become activated. And that tends to drive the inflammation and tends to drive the long COVID. That's only one of the causes, of course. I believe that there are four total causes for long COVID, and everything else is secondary. So the four primary ones, I believe, is with the dysautonomia, the mitochondrial dysfunction, gut dysbiosis, and MCAS or excess histamine. And they're four separate causes. They are interlinked. They drive each other a bit, but each one has their own set of mechanisms in how they perpetuate the symptoms of long COVID
Hmm.
and cause pathology.
Okay. So the immune system is in the first scenario of the dysautonomia, the immune system is in a perpetual fight mode and it's not turning off properly or clearing properly where we would eventually get to a point where there's like a resolution of an infection. It's stuck in an on position. Is that another way of saying it?
It's stuck in an on position and it's angry. And not only does that promote autoimmune conditions because the immune system just doesn't know what to do with itself,
Mm.
it promotes chronic inflammation because these inflammatory markers, inflammatory mediators are continually released over and over.
Okay. So those inflammatory mediators, just for the layperson, what do we call those? Cytokines, or are they more? Are we talking more on the macrophage neutrophil level?
We're calling them cytokines. The three big ones are tumor necrosis factor alpha or TNF alpha, interleukin 1 beta or IL 1 beta, and interleukin 6. Those are the main three inflammatory mediators that start the process going. There is some inflammation from activation of macrophages as well that occurs in the spleen. It's all connected.
Okay. Yeah, so my experience with long COVID is the people who have these chronic brain fog, malaise, fatigue. This points back to what you're talking about, because they have this perpetual elevation of these cytokines that actually affect our brain. Is that correct?
Yes, sir.
Okay. So dysautonomia, in kind of a definition of that, is that the nervous system that runs behind the scene, the autonomic nervous system, is disrupted. So most people take this definition and they'll point to vagal nerve pathways as being involved in a dysautonomia scenario. Is that how you is that one of the branches of the autonomic nervous system that we're talking about in this dysfunction?
If we look at the autonomic nervous system, it's automatic.
Yeah,
Automatic.
right.
Like as you said, it occurs behind the scenes. It does things that you don't have to think about, such as your heart beating or producing tears. All these things happen behind the scenes. You have two branches of it, okay? The parasympathetic, which is the rest, digest, heal, and the vagus nerve is part of that, but it's not the entire parasympathetic nervous system.
Mm-hmm.
And you have the sympathetic, which is the fight or flight. Those are the two main separations. And the vagus nerve is very important, especially in long COVID, because not only has it been found to be thickened on imaging, both ultrasound and MRI, but it's also been shown to be dysfunctional or not functioning as well as it did prior to COVID.
Mm-hmm. Okay, so most people don't realize that the vagus nerve is involved in inflammation management or inflammation regulation. And I think that would be helpful to go into that a little bit to see the connection here between all of the kind of pro inflammatory scenarios of long COVID, and then how the vagus nerve being disrupted would also add fuel to the fire.
Sure. So the vagus nerve main anti-inflammatory pathway is the cholinergic anti-inflammatory pathway. Now this works through a nicotinic receptor. Yes, nicotine also binds to it, but that doesn't really apply here. It's a subsection of a nicotinic receptor. It's called an alpha 7 nicotinic acetylcholine receptor. Okay, I know it's a mouthful. That one in particular is expressed on immune cells, especially and dendritic cells, which exist in central nervous system, especially in the brain. And it actually helps reduce the activation and inflammation in those cells. It also binds to other receptors and reduces a transcription factor called nuclear factor kappa beta. Again, a mouthful, NFKB. And this is the main transcription factor that causes inflammation or inflammatory markers to be made. Things like the tumor necrosis factor, the interleukins are produced when this transcription factor is activated. So what this pathway does is it quiets that whole system down, and that's the main way it works. Now there's a secondary pathway, the splenic sympathetic anti-inflammatory pathway. However, the vagus nerve does not innervate or control the spleen. It works indirectly to reduce and regulate inflammation there through what's called an inflammatory reflex.
Okay. Yeah. It it was always really interesting to me because when we hear about the vagal nerve, the first introduction to the vagus nerve is this the winding nerve that innervates pretty much most organs of the body. And when you learn that disruption in it or actually intervening in it to balance it can calm inflammation, it's mind blowing because many of the conditions that we're seeing, such as autoimmune conditions, are, you know, the target of those conditions are to reduce TNF alpha and IL 1 beta and some of these inflammation markers that we're talking about. And then you learn that, wow, there's a way to support the body through the vagus nerve that also dampens these inflammation markers. It makes it exciting to learn about vagal nerve interventions. And so your YouTube channel is remarkable. And this is the way that I got to know you because I was desperately looking for a way to teach my patients how to properly use vagal nerve stimulation for these particular benefits. And there are so many vagal nerve devices on the market, and some of them are extraordinarily expensive. And then I found you, and it's like with a very straightforward, affordable device and with very clear instructions, we're able to set people up with these devices. So let's talk about that. So
Sure.
you've really done a great job of understanding how to access the vagus nerve through um, various stimulators devices. What did when did you start learning about them, and what's been your kind of journey and process with trans uh, transcutaneous vagal nerve stimulation?
I've known about this even prior to long COVID, even prior to PTSD. It's something that I was researching into earlier because it was of interest to me, especially the ear. Because why the ear? Why does the vagus go in the ear? Why does it come from the ear? So that's where it started.
Okay. Yeah. So, yeah, I think people sometimes, when we're teaching this to them, they have a hard time believing that clipping a device up to your ear is actually going to affect this really important nerve that does all these fascinating and amazing things in the body. So let's talk about that. So, what is that access point that you're talking about?
So let's first explain what the vagus nerve is made of. It's a mixed nerve, which means it has sensory fibers, which are called efferents, which let it listen to all the organs that it's contacting. And then you have the efferent fibers that act, basically are the lieutenants, and they actually perform the actions that the vagus nerve wants. And then you have pain fibers in there as well. And of course, the autonomic component is in there. It's interesting that the vagus nerve is mostly composed of the listening fibers, the afferents, with the
Hmm.
A. About 80% of all the fibers in the vagus nerve are listening. They're listening to the body. Okay. And that's exactly the portion that we're interested in harvesting in the ear. The best place to access those afferents are in the tragus, which is this little flap in the beginning of the ear, or the symboconcha, which is this part. I don't know, it's
Hmm.
hard to see, but those are the most dense areas with those afferents. Now, it's pretty hard to get a clip to stay on the symboconcha as much as you'd like for it to be there. So we choose the tragus because it's very convenient. It's a great place to clip. And what's interesting is because it's affecting and activating the afferent fibers, it's really only activating the central pathways to the brainstem. Okay. That is it. It's not going to the heart. It's not going to your lungs. It's not going to your gut unless you really crank it up significantly. But for the most part, it's very safe because really we're going through a third party. We're going first to the brainstem, okay, to the nucleus tractus solitarius or NTS. Okay, that's the place where all the signals from the vagus nerve collect.
Hmm.
And it sits in the brainstem. And then from there, It goes to the dorsal motor nucleus, or DMV, not division of motor vehicles. And that part is what acts on the vagus nerve. But one other thing I'm going to mention about this area, the NTS, is not only does it pick up all of the signals, the cytokines, those inflammatory markers, and react to it from the body. So in normal cases, when we don't have long COVID, if you have an inflammation, or if you have inflammation of your immune system, those cytokines will act as a negative feedback. They will go up into your brainstem and into the NTS, and will actually activate the vagus nerve, and it will quiet things down. But when you have an underfunctioning vagus nerve system, right, it's not working well, it's not going to be able to quiet it down on its own. There's a lot of things the vagus nerve does in the brain that are important, but we can get to that later.
So, in a perfect scenario, the vagus nerve would be used as a regulation of inflammation, but in dysregulated inflammation that we're seeing, like with long COVID, this system's disrupted. And so these techniques of going in and helping stimulate the vagus nerve is basically piggybacking on something that should functionally be working, but it's not.
Yes, exactly.
Okay, so this is really interesting. Speaking to an anesthesiologist who, if anybody knows nerve pathways, it would be an anesthesiologist, because it's like a lot of what you're doing is working on nerve pathways and reduction of pain through knowing neuroanatomy. So when you first started working with these regions of the accessory branch of the vagus nerve, did you go through a period of time where you weren't convinced that you could really target well through this mechanism, or were you fairly certain from the get-go?
No, I wasn't certain. I had to do quite a bit of research to convince myself that stimulating something in the ear could actually help with the vagus nerve.
And I know there's tons of research out there about this. So was your did you get convinced clinically through reading research? How did you come to a conclusion that this was actually going to be useful in patients?
My main source was treatment of certain medical conditions with vagus nerve stimulation. So the very first thing that came about was refractory epilepsy, basically epilepsy that wasn't responding to medications. No matter how much medications you threw at it, the person still had epileptic episodes and seizures. And implanting a vagus nerve stimulator resolved the problem. This was followed by inflammatory bowel disease, such as ulcerative colitis and
Yeah.
Crohn's disease, and even rheumatoid arthritis seems to respond to vagus nerve stimulation by reducing the inflammatory response. That's what got me into looking at something that was non-invasive or minimally invasive, and it led me to the ear.
Okay, so most of those studies talk about vagal nerve stimulator implants, however, right?
Yes,
Um,
sir.
is there a parallel in what responses we're seeing, or is this sort of what I've heard, and you can clear this up for me, is that the implants have the ability to grasp more of the vagus nerve, and the ear stimulation is not as broad in its ability to access the vagus nerve. Is that a fair description?
So let's split up the types of stimulation of the vagus nerve. There's really two types. One is the auricular, or the ear, and the second is the cervical, or in the neck. Now, the vagus nerve runs very close to the carotid artery, which is one of the major arteries in the neck. It's about 6 to 7 millimeters deep from the skin. So it's not as easily accessible at the neck as it would be at the ear. But they actually do different things. When you stimulate the nerve directly by either wrapping it around the vagus nerve, or um, have the stimulation probe right next to the nerve, you're activating all the efferents and a lot of the afferents as well. So that has a lot of different effects, including side effects. One of the things that we can see with that is bradycardia, which is slowing of the heart rate, especially on the right side, which is why they usually implant it on the left. And it would have both effects on the brain and all of the organs. So the gut would start digesting and you'd be secreting acid and you'll see peristalsis and your stomach will be grumbling and you may even get diarrhea. And you may have issues with shortness of breath, for instance, because the vagus nerve shrinks or closes down the bronchioles. So there's a lot of other impacts with directly stimulating the vagus nerve. Now, of course, in somebody who has epilepsy and can't function, in that case, it's the benefit outweighs the risk, and they take the bad with the good. I mean, look at chemotherapy agents. I mean, they're killing you just slower than the cancer is. So sometimes you have to do something that has quite a few risks associated with it in order to treat a medical condition.
Mm-hmm. Whereas the transcutaneous vagal nerve stimulation, the side effects are negligible.
They're negligible at the ear, if you do it at the ear. And now there are some devices that do recommend stimulating at the neck.
Yeah,
Okay.
I've seen those. Yeah.
And if you notice, those sessions are typically 1 to 3 minutes.
Yeah.
They're very short because if you continue stimulating, you'll not only get the side effects, but you'll also get what's called habituation. And when the nerve gets hit with kind of a sledgehammer over and over again, it stops responding or it doesn't listen as much.
Mm-hmm. Mm-hmm. Okay. So with all the products out there in the market these days, did you arrive at the 10,7,000 from a standpoint of practicality or cost, or just based on efficacy, or what goes into that? Because I've seen so many out there, and some of them look, I'd say, fancier and like a little dressed up. Maybe that's just for marketing purposes, but I'd just love to hear your thoughts, because I actually, like I said, I bought a 10,7,000. I use it with some of my patients, and it works great. And I see these other devices, and it's like tempting to think, am I missing something with some of these other fancy $700 units?
That the 10,7,000 runs about $35. And for our purposes, it does what it needs to do. That's why I chose it. I chose it because I want it to be accessible to every single person who can't afford $35 to purchase. Not everybody can afford a $700 or $1,500 device. Mm-hmm. So that's number one. It doesn't matter if it's digital or analog, if it has knobs or buttons. The point is, as long as you can alter or change the frequency and the pulse width and the intensity, you can use the device. Now, there's a lot of TENS devices out there that have different modes like EMS or burst. We just want a regular waveform, a normal waveform, what's called a continuous waveform. The 10,7,000 produces a monophasic, which means it's only positive. There's no negative component, and it's a square wave. Now, there's fancier units out there that produce sinusoidal waves and triangular waves, but really there hasn't been any study showing benefit of one waveform over another. Why not go with the most accessible and cheapest unit that's available? Now, granted, it is meant for TENS, right? It's meant for muscles. It's a muscle stimulator. You have to use some prudence in selecting the intensity, because you can easily crank up the intensity too high and cause discomfort, or even possibly damage. If you're using a device like that's not meant, and it's obviously not FDA cleared or anything for any nerve stimulation, so you have to just be cognizant of and be aware of the settings.
Right. Yeah, and I think that's your YouTube channel does a great job of in multiple ways educating on the setup and the duration and the intensity of the sessions. And I do think for some people who don't want to mess with, or to use a Yiddish word, futz with the settings. They might not want to, deal with the technicalities, which is it's really simple. You're
It
talking
takes
just
less
like a
than
couple
15 seconds.
knobs.
Yeah, it takes 15 seconds to program.
They might go with the one that's just like a button and pre-programmed. But yeah, it's really interesting to hear how you derived at that. And the fascinating thing with working with patients with this is, I would say, and I'd love to hear your thoughts about this, is there's some people who just respond beautifully. And I've had patients tell me it's like long COVID patients and other patients who are dealing with chronic fatigue syndrome and various things tell me that it's their favorite part of the day. It's like the session and the after session and however long the effect works, that they look forward to it every day. And other people is, I don't feel anything. It doesn't do anything for me. What would you say the percentage of responses in your practice for people who actually report benefit?
I would say more than 70%. So part of this is identifying dysautonomia. So is there a dysautonomia? Is there vagus nerve dysfunction or not? Because if there isn't, treating it is going to still help with healing, but it's not
Yeah.
going to really correct anything.
Yeah. And so in my practice, and I'd love to hear your thoughts about this, is I look at tracking heart rate variability and looking at HRV as a marker of dysautonomia. And is that a good basic way to assess it, or do you use questionnaires, or do you use physical exam findings? What's your kind of process of quantifying the level of dysautonomia?
So there's two ways to quantify it. One is resting heart rate, when somebody is sitting in a dark room, not thinking about anything, not watching anything, not talking to anybody, what their native baseline heart rate is. Ideally, we want it in the low 60s. Really, 60 to 62 is where we want most people who don't have sympathetic overdrive or fight flight to be. The second is heart rate variability. I use it as well. It's not as easy to track, although you can get a baseline, because other things affect HRV besides dysautonomia. If you haven't slept well, if your nutrition is poor, if you're sick, but it gives us a sense of how severe dysautonomia is.
Mhm. Okay. And then what about things like orthostatic readings and of blood pressure compared to heart rate? I know not classic like POTS evaluation, but just something that along those lines. Is that a good way of measuring things like lying down, seated, and standing blood pressure, heart rate readings?
So you can do that kind of test at home. It's a lean test. You just need an extra person and to read the numbers and to press the button, and you need a pulse oximeter and automatic blood pressure cuff. That's it. So that's a way to see if you are diagnosed with POTS or orthostatic hypotension, and they're mutually exclusive diagnoses. So it's either one or the other. You can't have both. And orthostatic hypotension is more severe.
Both falling in the dysautonomia category.
Yes, they're both subsects of dysautonomia. Their main effects are on heart rate and blood pressure, but obviously other symptoms can also coexist within POTS and orthostatic hypotension.
Okay. So I want to go back a little bit to your comments about 70% of the people are responders if they truly have dysautonomia. And so are you pre-selecting for people to use the vagal nerve stim based on dysautonomia, or do you use it in other settings and find it beneficial if people don't have dysautonomia?
I think it's beneficial in other settings as well. There's been several studies showing its effectiveness in migraines and cluster headaches, for instance. And it's effective in other forms of pain because the vagus nerve interacts with several areas of the brain that control pain. The anterior and the mid-cingulate cortex um, basically perceive pain. This is where you sense and respond to pain. So because it works on those areas, it also helps pain in general.
Mm-hmm.
So there's many other areas outside of dysautonomia where vagus nerve stimulation could be useful.
Mm-hmm. Mm-hmm. Very good. So with your patients, obviously this modality is not a cure for long COVID. It's a way of helping manage and deal with long COVID. Do you position it as part of an integrative treatment program that you're doing, or do you is are you looking at this as more of um, that dysautonomia is one of the root causes, and this is a treatment for dysautonomia?
I use it as a treatment as well as an integrative part of the therapy. Even if, like I said, even if a person doesn't have dysautonomia, I usually include vagus nerve stimulation just about everywhere with every patient because it's very useful. Unless it's causing side effects or problems for the person, they're only going to benefit from it. It is a treatment, but it's a very slow and deliberate treatment, which means that you have to pick people who are going to be doing it for at least 90 days, if not longer. If somebody wants a result in a weekend or in a week, vagus nerve stimulation is not going to be the treatment for them. This is where I combine it with my other two procedures, which is the stellate ganglion procedure and the EAT procedure, to basically close off the treatment plan.
Mm-hmm. Okay, so your those are the pillars of your treatment. I definitely want to go into learning more about the EAT procedure in a second here, but are you doing, because I've read one of your books so far and I'm going to definitely download the others, but are you looking at all aspects of a long COVID approach, or is your approach strictly through these neural pathways?
No, as I said, I focus on all four of the causes. Now, the other potential causes that you mentioned, I believe, are secondaries. So things with hypothalamic pituitary adrenal axis that are disrupted, those are secondary. Hypercoagulation is secondary. But the top four that I focus on, and I actually treat in the office, are the dysautonomia, which I already told you how I do. The mitochondrial dysfunction, I use a 4-step protocol for that I came up with. And gut dysbiosis, I focus on leaky gut and improving the microbiome. And lastly is the MCAS or excess histamine. And there we hit it from 2 points. One is reduction of intake of histamine, uh, reducing, my light keeps going out.
It's okay.
I'm sitting behind a monitor. Basically, reducing the intake of histamine, reducing production of histamine, and increasing the elimination of histamine. Remember, mast cells don't just have histamine; they have over 100 different proteolytic enzymes and cytokines, and even heparin is in there,
Right.
which is a blood thinner. We're only looking at histamine, but when a mast cell degranulates, it actually causes a lot more damage in the surrounding area than just hives.
Yeah. 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 So it's really, I think, why this is such a complicated condition to treat. And I think a lot of the long COVID centers that I see just park people and want just to wait so this will eventually self eliminate. But that's not really happening in most cases. There needs to be something done to help balance the biochemistry. And I'm really glad to hear that you're looking at this holistically, because I've had patients go to certain long COVID centers and basically they're put in a class for cognitive behavioral therapy, maybe some biofeedback, and told just to ride this thing out until it goes away. But as we've learned from the populations of fibromyalgia and chronic fatigue syndrome, it's not that easy to just think that this is just going to self resolve. Post viral syndromes need these types of interventions for sure.
So, thanks to long COVID, I think we've learned quite a bit more on chronic fatigue syndrome. And actually, it's helped me treat that as well,
Right.
because a lot of the therapies came out of the long COVID, even though chronic fatigue has been around much longer. So,
Exactly.
what I find is when patients come from another long COVID clinic, they're gonna fall into one or two categories. The first category, as you said, is going to be cognitive behavioral therapy, maybe some mindfulness and physical therapy. The second type is going to be tested. They've had blood work, the whole catalog of blood work, but nothing was actually done. So they've had everything tested, and they bring in a booklet about that thick of labs, including TIL tests, including EKGs, including EEGs, you name it, it's in there. And great that you've tested all this, but now what are you going to do about it? Nothing is getting done. The person is told this is wrong, or nothing is wrong, or no imaging is abnormal and can't help you, or they tell them a few things that are wrong and nothing really is done. Or usually it ends up being like a POTS treatment: increase fluids, increase salt, wear
Right.
compression garments, on the usual medications to increase your blood pressure, slow down the heart. But what's important is POTS is not dysautonomia. Dysautonomia is POTS, but POTS is not dysautonomia. So treating POTS will not treat the entirety of the dysautonomia that long COVID causes.
Mm-hmm. Very good. Very good point. So you mentioned the EAT therapy, and can you talk a little bit about that? Because I think that's new to me, and I'm sure new to people who are listening.
Sure, the minute I saw it, that there was a video on it from Japan, and I'm looking and seeing that not only does it affect the vagus nerve, but it also reduces the cytokines, and specifically in an area that you can't access. You can't access this through the ear, and you can't access this through the neck. Okay, this is an area that's protected under the mucus.
And so the acronym stands for what?
Epipharyngeal, that's the E. The A is abrasive, and T is therapy. So the whole point of this is that you're rubbing the area between the nasopharynx and the oropharynx, basically the back of the nose or the back of the throat. You're not gagging, don't worry, it's all numbed up. And you're removing some of that mucus that's covering potential pathogens or remnants of viruses, bacteria, and fungus
Mm-hmm.
that are hidden back there. But because they're hidden, they continually cause a low level of inflammation. So by causing that area to bleed, or to basically clean it out, that whole area cleans out. Um, the vagus nerve is pretty much entirely in charge of that area. And by
Okay.
rubbing that area, you're really activating the vagus nerve in a unique
Wow.
way that you can't normally do. Now, this is
Wow.
done under direct visualization. That means I'm actually seeing what's happening live at the same time as I'm doing it, using a very thin, flexible camera called an endoscope. It's called a nasal endoscope. And it can help things that the stellate ganglion block can't address, or the vagus nerve stimulation can't address.
Mm.
Things like tinnitus, things like Eustachian tube dysfunction. So if you're having
Wow.
coolness in the ear, or if you feel like you're underwater, and even tinnitus. One of the most stubborn symptoms that I've had trouble with stellate ganglion block procedures, and that's been pressure headaches, or head pressure, or face pressure that wasn't really responding to any other treatment.
Mm.
To respond to the heat therapy.
Interesting. So is that like biofilm that's kind of covering this area? Is that what you would call
Oh,
that?
it's beyond biofilm. It has a thick layer of mucus there. We're talking, yeah. I mean, it's hidden well behind there. Your immune system can't really touch it.
Okay.
It's trapped in a layer of mucus, and we just got to get rid of it.
Really interesting. And so are you diagnosing that first by doing the like a more of like an endoscopic exam, and then from that someone's a candidate for this therapy, or is it pretty much always there in these long COVID patients?
So I use a questionnaire that looks at the most common symptoms that would be relieved by EAT. And if somebody scores a score that meets the threshold, I would do the procedure. If I'm already putting the endoscope in there, I'm already numbed them up, might as well do the procedure at least once,
Mm-hmm.
because you really can't tell until you start rubbing the area
Oh.
with the zinc. It may look clean and normal, but as soon as you start rubbing, it's all bleeding,
Mm.
and that tells you it's very inflamed.
Interesting. And so did you have to go to Japan to learn how to do this, or did you learn through like another way?
I learned it through another way.
Interesting. And I imagine there's very few people in this country offering this. Are you finding that you're like one of the only one?
I think I am the only one, pretty much outside of Japan. I think I'm the only one that's offering this. And the more I'm doing, the more I'm learning better ways to do it.
Mm-hmm. Can you share a couple of success stories with that technique?
Sure. We had a young lady who was in high school, and she loved to sing, and that was one of her passions. And since she developed long COVID, her voice was changed and lower and raspy, and that completely resolved post procedure.
Wow.
And she was able to really get back to what she loves, which is to sing.
Wow. That that's life changing. So,
For her, it is, yes.
yeah. Yeah, I think I've had some patients in my office that are in the opera or singers, and they're going through these voice changes, and it's devastating. So to be able to address that is life changing for, like you said, for her or for the person.
But do you know why that's happening, the voice?
I think the traditional way that we think about this is they'll go in and look for like vocal polyps or other damage to the vocal cords. And sometimes they'll see something and sometimes they'll see a maybe. It's the maybes that really throw everybody off because nobody will do anything about a maybe.
There's nothing wrong with the vocal cords. This is innervation. We're talking about what controls the vocal cords. It's the recurrent laryngeal nerve, it's the superior laryngeal
Mm-hmm.
nerve. All of these are branches of the vagus nerve.
Vagus, right.
So
Yep.
if vagus nerve is not functioning properly, it's not going to let the efferents that come off it function properly. So yes, you're going to
Mm,
have changes in swallowing, changes in your voice.
very nice.
Um, and that's how we also know that the vagus is so much involved in this.
Interesting. I always talk to people about um, this really troubling condition called LPR, which is the laryngeal pharynx reflex, I think is the name of it. LPR, it's like a reflux disorder that's associated with GERD, but it's happening higher up. It's like a chronic clearing of the throat that people, it's so much more difficult to treat than GERD. It doesn't always respond to acid blockers and is really frustrating for people. And this reminds me of that this might be something to look at. As I'm always talking to those patients about vagal nerve balancing because there tends to be a lot of vagal nerve imbalance in people who have this disorder. Do you ever treat LPR?
I don't.
Okay. I'm interested to see if there's a connection there. So before we wrap up here, I'd love to just hear some takeaways and things that you would love for people to know about your practice, potentially if you are accepting patients and kind of the way that people would follow your work.
Sure. I do telehealth pretty much around the world. And if you want to get a hold of us, covidinstitute.org is the place to do it. There's a contact us button. You can request an appointment even if you don't speak English. We have translation in 240 languages and dialects. Although I haven't had too many takers for those. Yes, we're accepting new patients, trying my best to take care of as many people as I can, help as many people as I can. My practice is very evidence-based, which means I don't just take a catalog and order the entire catalog. We actually figure out what causes are involved. Those four causes that I mentioned: the dysautonomia, mitochondrial dysfunction, gut dysbiosis, and MCAS or excess histamine. And then we attack each of the causes, figure out which one is the most responsible, and then we work on the next one, then we work on the next one. So the tests are very specific to determining what causes are involved, and the treatments are very specific to the causes. So we're not chasing symptoms. We're not chasing the symptoms. The symptoms will disappear once you treat the cause. So that's pretty much how my practice is structured. I believe I'm the only one in the world outside of Japan, and maybe in the world period, that offers both EAT and stellate ganglion procedures under one roof. So if you have stubborn symptoms and they're not going away with the usual treatments and supplements and therapies, give us a try.
Excellent. Thank you very much for your time. This was really informative and exciting to learn about such an organized, root cause oriented treatments, and things that, like you said, I don't think anybody's really doing in such magnitude. So thank you. And I really, on behalf of my patients, thank you a lot for your education, especially with the vagal nerve stimulation, because it really has given people moments, hours, days of relief, and just being able to have someone confidently teach that technique is very helpful, because I think people are afraid to do things like this without someone hand-holding. So thank you for that.
Absolutely. My pleasure.
All right. And I look forward to keeping in touch with you and maybe doing further topics down the road.
Sure thing.
All right. Thank you. Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.